This is lesson 1.4.1, Government versus Private Payers. In the previous few lessons, we've discussed how to get a new technology, whether it's a drug or medical device, approved for sale. However, just because it's approved for sale doesn't mean that it will be paid for. In this lesson, we'll discuss how to get a new technology reimbursed or paid for. First, let's consider the case of prescription drugs. There's two interrelated steps. First, you need to get insurers to pay for them. If it's a drug, that means getting the drug added to the formulary. Second, you need to get patients to use them, which means that you need to get doctors to prescribe them. So, how do drug companies influence prescribing behavior? Well, first, the physician or patient demand influence can lead to formulary admittance. So if physicians say they want to prescribe it, or if patients say they want their doctor to prescribe it, it may influence the insurance company to add it to a formulary. Second, companies need to demonstrate that the new drug is effective, or even better, it's cost effective. One way to do that is through published results from medical technology assessments. We'll discuss formularies in more detail in previous lessons, but as a side note, a formulary is a list of drugs and an order in which they're reimbursed. So next, let's consider the case of medical devices. These are slightly more complicated than drugs. So the first step is the same. You still need to get insurers to cover them or pay for them. Second, you need to get hospitals and physicians to buy them. Then you need to get physicians to prescribe them or implant them or otherwise use them. So similar to drugs, you still need to get insurers to cover them and physicians to prescribe them and patients to use them. But there's an intermediate step where the hospitals actually buy them, and once they're used, they're reimbursed from the insurance companies. Now, devices are used in many settings, and the flow of payments and access to therapies is more complex, so that's worth considering when performing any type of technology assessment. So types of questions to ask are, where are the medical devices implanted, used, or prescribed? Is it only hospitals? Is it potentially doctors' offices? Or outpatient clinics? Or some other situation, possibly at a patient's home? Second, who buys the medical devices? So as I mentioned just a minute ago, there's many types of devices that physicians or hospitals purchase and then use and are reimbursed for. It might be the case that patients buy them directly, that hospitals or physicians buy them, or that there's some other situation, such as nursing homes or long-term care facilities. And another question to ask is, why is the patient's health insurance important? Well, it might be the case that a device is covered, but even if it's covered and the patient has to pay some portion out of pocket, it could be a significant cost to the patient, even if it's only a small cost of the device. That could ultimately affect use. These are all important questions to ask when trying to bring a drug to market, and they're important questions to remember and understand when performing a technology assessment. Overall, payer coverage, whether it's a drug or a device, is based on a hierarchy of evidence. It's important to show economic outcomes. In other words, that a new device or technology is cost effective. More important than that is to show that there are clinical outcomes. Insurance companies don't want to pay for drugs that don't do anything that the current technologies don't offer. Above that, any type of marginal clinical outcome, it still needs to be the case that the benefits outweigh the risks. So even if there's small clinical improvements, but the side effects are significantly worse, it may not be in the best interest of the insurance company to pay for it, because they may end up paying for more health care due to the side effects. And on top of that, it needs to be the case that the drugs are safe and effective. Theoretically, this has already been proven through FDA approval, but insurance companies are interested in this as well. Now, we've talked a lot about insurance companies, but there's a slight difference between an insurance company and a payer. An insurance company is a commercial entity that covers commercially insured patients. Medicare is a government program that acts like an insurer, but is often referred to as a payer. Anyone over the age of 65 and some people with disabilities can enroll in Medicare. Medicare makes two types of coverage determinations, similar to an insurance company. However, they cover a population that's much larger than any commercial insurance company. The first of those coverage determinations is called a local coverage determination. Here, coverage is determined by medical directors of local contractors that operate payments for Medicare patients. So when Medicare patients receive care, the doctors or hospitals that provide that care are reimbursed through these local contractors. This is a decentralized decision-making process, meaning it could differ from contractor to contractor or location to location. One way to think about this is states in the Northeast United States could have different coverage determinations than states in the Southwest. The coverage determinations are usually responsive to community care standards. So if the Northeast has a different type of population than the Southwest, even though everyone's over age 65, but they may have different types of common health conditions, there may be different types of coverage determinations. Now this does in some sense allow for prompt initial diffusion of innovations. If the population of interest is in a certain location, those local contractors can make decisions quickly to add new technologies to the payment schedule. However, it's not always the case. The other type of coverage determination is a national coverage determination. This means that the Medicare program overall, at the national level, or for all states, is a single decision. And these coverage determinations at the national level must be adopted by all Medicare carriers and intermediaries, which means all of the local contractors must abide by this coverage decision. Once a coverage decision has been denied, there's limited options or limited opportunities to go back and appeal the decision. And a coverage decision at a national level can also be an external or internal request. So Medicare itself can request review of payment for a new technology or drug, or a manufacturer or pharmaceutical company can request review for payment determination. Coverage with evidence determinations require the collection of additional data in exchange for Medicare coverage. This could be from clinical trials, or could be from post-market surveillance, or it could be technology assessments. It's important to note that approximately 10% of coverage decisions are national coverage decisions, which means that when bringing a new drug to market, you shouldn't count on a national coverage decision to get Medicare coverage, but you can't count on all local coverage decisions to go in your favor either. Overall, Medicare coverage relies on a variety of factors. Generally, CMS, which is the Centers for Medicare and Medicaid Services, have the standard of reasonable and necessary to meet in order to obtain coverage. So they broadly focus on a few items when making this determination. There's methodological considerations and the relevance of the chosen outcomes and clinical endpoints, which means they examine how the clinical evidence was collected or the statistical analyses were performed to demonstrate effectiveness, if the types of outcomes that were measured are relevant to the population being studied, how well that study generalizes to the Medicare population. For example, if the study was performed on children under the age of 18 and the Medicare population is largely composed of adults over the age of 65, the study might not generalize well. And finally, there's a qualitative assessment of net risks and benefits. This includes some review of all of the scientific data, as well as more qualitative assessments of the types of risks and benefits to a large national population. In general, CMS does not formally consider economic information in the coverage process. This would be something like a cost-benefit analysis or a cost-utility analysis. There are other countries that do consider this type of evidence. Medical carrier medical directors, or the local contractors, also consider the expert opinion of clinicians in their area when developing local coverage determinations. So this is important to demonstrate to the local physicians that technology is cost-effective, or at least effective, because their influence and opinion can determine or help determine the local coverage determination, which can help ultimately determine whether or not a new technology is paid for and will survive on the market. Finally, private insurance. There's less to say about private insurance because much of what's determined by the private insurance companies is influenced by Medicare. So Medicare is often the first payer that new drugs or technologies are worried about getting coverage from. But private insurance is largely in the United States paid for in part by the employers. However, it's ultimately the workers that receive the coverage, and workers do pay some portion of premiums, and it's been shown that in some cases, better insurance benefits compensate for lower wages. So all in all, there's a back and forth between employer-sponsored insurance and the workers. And it's important to remember that all of these technologies are ultimately used by the patients. For anyone that doesn't receive insurance through employers, they often can purchase healthcare through individual markets. Additionally, there's different types of employer insurance. Some large employers are self-insured, meaning they have enough money to keep in the bank to insure themselves, while others are not self-insured, and they're considered fully insured, which means that they just purchase an insurance plan directly from a commercial insurer, but they do it on a large scale, just like an individual would do it on an individual scale. In all cases, whether it's individual, self-insured, employer-sponsored insurance, or fully insured employer-sponsored insurance, the payment rates between doctors and hospitals or other healthcare providers and the insurance companies are negotiated between those insurers and healthcare providers. The payment schedules can vary, and there's a variety of ways in which payment negotiations can occur. One type of payment schedule is called capitation. In this system, every doctor or hospital that contracts with an insurance company is paid a fixed amount of money to treat any patients from that insurer. If they end up treating patients with amount of services that cost more than what they pay, they lose money. But if they treat patients for less than what they're being paid, they make money. Carve-outs are another type of contract that can be negotiated between insurers and providers. In this case, it's a separate payment for certain services outside of the regular overall contracts. And finally, there's payments that are similar to the payment schemes developed by Medicare, and they're based on a series of codes that include diagnosis codes and procedure codes and the amount of visits or inpatient days that a patient receives or obtains with a healthcare provider. Insurance companies have coverage committees that review the evidence and decide what to pay for. Now, they often follow Medicare's decisions, but they have the ability to use additional evidence, and cost-effective evidence may be helpful for influencing the insurance company's coverage determinations.